I think that's me.
Yes. So the next speaker is Dr. Ben Samstein. He's professor of surgery and chief of liver transplant and HPB surgery here at Cornell, and will tell us about pushing the envelope in metastatic disease.
All right. Can you hear me and see my slides?
Yes.
All right. So I'm gonna pivot a little bit from Brandon's talk on um, um, early colorectal cancer, and we're going to be talking about metastatic disease, and we're going to be talking about pretty invasive therapies. So um, I have no disclosures relevant to this talk. So I'm going to introduce a case, and we're going to talk about the concepts for people with colorectal cancer with liver metastasis. We're going to talk about liver transplant as a treatment modality, a little bit about selection, and how the strategies all combine. So starting with this case, this was a 60-year-old woman with rectal sigmoid adenocarcinoma in December of 2020 and had multifocal bilobar colorectal mets. She underwent a low anterior resection in 21 and had a colostomy. She had lymph nodes positive. She had 4 out of 35 lymph nodes, and she was um, and so you can see her TNM staging there. She underwent a hepatectomy for her colorectal mets. She had a resection of 7 lesions in segments 3, 4, 5, 6, 7, and an ablation. That was in January of 22. And she was received 12 cycles of systemic therapy. Um, After she had, toxicity from chemotherapy, had 5 months off of chemotherapy, got a repeat hepatectomy in January of 23, resection of 3 additional lesions, and ablation. Um, and 10 more cycles of systemic therapy. She was then referred to us for after the second round of systemic therapy when she had 6 new lesions. So if you're counting lesions, she had had a total of now 16 liver lesions. After her primary was removed, her CEA was 12, and her mutational analysis of her tumor showed her KRAS was wild type. She was BRAF negative and HER2 negative. And you can see that on the imaging below, she had disease. It continues to be bilobar disease. I don't know. You may not be able to see my pointer, but I don't know. Let's see. I can use a. Let's see. Can you see my pointer? I don't know if anyone. But she
Yes.
had disease
Yes.
in the right lobe, as well as obstruction of the left lobe that's causing this uh, dilated ducts. Um, so that's the case. We'll come back to that in a few minutes. So people a lot smarter than me have discussed many of the systemic therapies that we've been discussing today, and the treatment regimens based on biomarkers. But there's also an enormous amount of now liver-directed therapies, some of which require surgery, obviously resection, ablations, hepatic artery infusion pumps or HAI pump, and liver transplant. And there are non surgical therapies. There's ablation, Y90 radioembolization, bland embolization, chemoembolization, cryoablation, um, external beam radiation, and a new therapy called histiotripsy or histiosonics using high frequency ultrasound. So many different modalities for um, patients with metastatic disease. And ultimately, I think that we have been getting better in people who have metastatic disease. And this is just a slide showing that if you look at over the last 20 years, the green bar shows that we have been improving in the patients with colorectal liver metastasis due to more effective systemic therapy, a more aggressive approach to surgical treatment. In other words, I'll talk a little bit about how we're able to be more aggressive, and better non-surgical therapy. So a variety of different treatments leading to improved survival. And more people are getting surgery. So it used to be very rare for people who had metastatic disease to the liver with colorectal cancer to have surgery. And now, although it's still a minority of patients, it is it's actually fourfold higher than it used to be. And patients who undergo liver resection, obviously there's a selection bias, but those patients do better than patients who are unable to have liver resection. So one of the modalities that has really been changed in our approach to surgical therapy is what's called parenchymal sparing hepatectomy. So this slide shows a variety of different scenarios. So in scenario A, patient has a single lesion and they undergo a surgery to remove a portion of the liver based on their blood supply. Whereas in a parenchymal sparing approach, you just remove the lesion. So really preserves much more liver. So in scenario B, a central hepatectomy would be the non-parenchymal approach, as opposed to B2, where again, you're removing 5% of the liver compared to 40% of the liver. And in someone with oligometastatic disease, E represents another situation where you would be removing large portions of liver in a non-parenchymal approach, and you can still remove less than 20% of the liver using ablation and surgery. This is a study which basically shows that as long as you have a negative margin, even a 1 millimeter margin, that the recurrence rate in colorectal cancer is low. And so that's become our preferred approach, as most colorectal liver surgeons who are approaching colorectal metastatic liver disease is we don't need 10 millimeter or 1 centimeter margins. We don't need to remove large portions of the parenchyma. And since we'll talk a little bit about the recurrence, but since the recurrence rate is high, we need to approach the liver with a sense that we're going to have to go back in this area using a variety of different treatments, which may all have cumulative liver toxicity. And so basically, that there's a value for removing almost all tumors. It's better if you have an R0, but even if you have to peel it off the vein, that those patients derive a benefit over someone who has gross disease. The other thing that's become really well understood in liver surgery is how much liver can you resect. And as we've come to understand how much liver can be resected, especially in people with extensive liver disease, we now routinely measure what's called the future liver remnant. In other words, the portion of liver that we will not be removing. And we make sure that in people who have multiple metastatic disease, that we leave them with enough liver. People who have had extensive chemotherapy, we need to leave them more liver than than people who have not had any chemotherapy. And there are a variety of modalities. PVE is portal vein embolization. There's also PVE and hepatic vein embolization, which seems to improve regeneration over PVE alone. And ALPS is where we do a two-stage hepatectomy with a ligation of the portal vein, also induces rapid liver growth and enables a very aggressive surgical therapy for patients with oligometastatic disease. So our goal, resect the disease with clear margins, preserve adequate liver volume, and an adequate margin just means a 1 millimeter margin. And these are relatively small studies, but basically showing the benefit of parenchymal sparing approaches over anatomic approaches. And we use at Cornell, and most programs are, a variety of different approaches for where we often are combining for people with oligometastatic disease, ablation in addition to resection. And this is a study basically showing that if you combined a minor resection and ablation versus a major resection, that you had overall survival that was essentially the same. These were in patients with 2 to 3 liver metastasis up to 3 centimeters, with a reduction in their major morbidity and a reduction in liver failure if you didn't do a major resection. And so that's our preferred approach, is parenchymal sparing whenever possible. This kind of, one of the things that often patients come to us as we discuss all of these different modalities, and I'm going to talk a little bit about biology. Is there a benefit towards giving people preoperative chemotherapy? Many times in people with high risk of recurrence, we will give preoperative chemotherapy, but the data says that the value is low, and that it's basically kind of a wash if you can do a resection and resect all the disease. Certainly, the number of metastatic lesions is associated with survival. So if you have a single lesion, those patients do better than patients with oligometastatic or high volume, 7 or more. And that patients who have an early recurrence, you do a resection and then they recur within a few months, those are the patients who are going to do poorly. And so I'm going to start talking about the patients with very high burden of disease and how we're approaching the patients who have bad biology or appear, based on the number of liver metastasis, who may have bad biology, how we're approaching those patients. So liver transplant has been a therapy now introduced for patients with relatively high volume, like the patient I presented in the beginning, multiple different unresectable liver metastasis. And what we do is we work closely with our gastroenterologists, our medical oncologists, our interventional radiologists, our diagnostic radiologists, all of whom we're working closely with to have the best outcome. So what do we need to know? Well, we've started talking about some of the things, ctDNA, the size of the tumor, the response to chemotherapy. I'll talk a little bit about lymphadenectomy and show a quick video of a lymphadenectomy, and obviously any extrahepatic disease. So there are two kind of highly used clinical risk scores, the Fong risk score, which is the number of liver metastasis, the tumor size, whether or not the liver metastasis was synchronous with the primary, and if the CEA was over 200 and the node positivity, and the Oslo score, which was developed for transplant out of Norway, which meant were they responding to systemic chemotherapy? Was the tumor size over 5.5 centimeters? Was the CEA over 80? And how long had they between having their primary colorectal cancer out before they had a liver transplant? So uh, the basically the liver transplant was developed in Norway, where they actually had a oversupply of livers, and so they started doing liver transplants for people with unresectable disease. In patients who have oligometastatic, so usually less than 5 lesions, very high recurrence rate. The majority of these patients will definitely recur. Patients who have unresectable disease, and I think Dr. Shaw was mentioning this, but these patients don't do well. About the 5-year survival is about 10%, and medical therapy alone is still with a pretty poor outcome. And so in SECA 1, which is the Norwegian trial, which looked at liver transplant, the 5-year survival was 5 times greater, 5.5 times greater for liver transplant over medical therapy alone. And these are the curves of the SECA 1 and SECA 2. And in SECA 2, when they selected patients based on the information of their earlier experience, the 5-year survival was even higher, well over patients. And this is the SECA 2 trial, which was published in 2020, showing 5-year survival of 83%. And although there was a high degree of recurrence, and we'll talk about disease, as you can see in this figure, disease-free survival was under 50%, but the patients were alive, and these were much improved survival over medical therapy alone. And in patients with a low risk score, what Fong 0 to 2, meaning they had none of the criteria, their largest tumor was smaller than 5 centimeters, their CEA was low, they didn't have synchronous disease, they didn't have positive lymph nodes. Those patients did very well with liver transplant, and patients with a low Oslo score in the SECA 1 and SECA 2 had a very good 5-year survival of 67%. So this is kind of looking at the combined. Norway still has the largest experience. We'll talk about the American experience, French experience, and our own experience in our patients. So 61 patients with colorectal liver metastasis transplanted. They've been now followed up for more than 10 years, or some of the patients over 10 years. And the overall survival, median survival, is 5 years. There are recurrences, you can see, even late, and the negative predictive factors are tumor size over 5.5 centimeters, progressive disease while on chemotherapy, a CEA over 80, a PET scan that shows that the metabolic volume of active disease is more than 70 cubic centimeters, a right-sided primary, or more than 9 colorectal mets. In the U.S. experience, there have been 64 patients who have been listed. This was published in 2023. There are now over 100 patients transplanted. The 3-year survival was 60%. I think some of it related to the heterogeneity of the different centers that were doing this. And um, so, and programs used both living donor and deceased donor. So you can see on the right, you can see green bars indicating living donor and blue bars indicating, or blue columns indicating the deceased donor. So both modalities being used for transplanting people with extensive disease. The paper that really brought a lot of enthusiasm to this topic is what's called the TransMet trial, which was a randomized controlled trial of 20 European centers. This was published last fall in Lancet. So 157 patients assessed for eligibility, 94 enrolled and randomized, and 47 in the chemotherapy alone, and 47 assigned to a liver transplant. And basically, it showed that this is kind of telling you about how much disease patients had. Most patients had stable or partial response. There were a number of patients who had high Fong scores, but most of the patients had low CEAs and small tumors. And there was a strong survival curve in the randomized controlled trial, 56 versus 12% for liver transplant versus chemotherapy alone. The overall survival per protocol was 73 versus 9%. So pretty impressive uh, survival benefit for liver transplant, although the progression-free survival was lower. And what we found, and this has been known, is that when you do a resection, a lot of the recurrences are in the liver. When you do a transplant, most of the recurrences are in the lung. And people who have lung mets actually do really well. You can see this is a slide from the Norway group on the right. And what you can see is that the survival for patients who have a pulmonary met as their only or first recurrence is excellent. It's the hepatic metastasis that really kills people. And this figure basically shows that after liver transplant, the majority of patients who recur, 62% occurred in the lungs, whereas those who have a hepatectomy, they're recurring at either multiple sites or high volume also in the liver. So getting back to our case, let's see. Let's see if I can. Yep. So this woman, she had five. So she had, as I had mentioned earlier, she had already had 16 lesions, but when she presented to us, she had 5 on PET scan. I'm going to just show you here. Oops. There's 1, 2, 3, 4, 5. Sorry that I can't seem to slow this down. But she had 5 lesions, still in the liver, still unresectable after all of her multiple resections. And she had been more out years from her original diagnosis. And she had been out 3 years since her primary. Her CEA was 7. Her volume was way under her her metabolic volume was over 70. So our treatment options include reinitiate chemotherapy, re-resect for a third time, hepatic artery infusion pump, or transplantation. So we reinitiated systemic therapy, and this is our experience. We've evaluated now more than 30 patients. Our protocol involves that patients have to have unresectable disease, that they have to have an excellent performance status. Most patients are ECOG 0, and that they have a negative chest CT and no evidence of extrahepatic disease. We remove the primary 6 months prior to listing, and they have to have an Oslo score of 0 to 2 at the time of listing, and then I'll talk a little bit about our preferred modality of using live donors. So, this what I'm trying to show here is that the number of patients who go through this process, people who have metastatic colorectal cancer, people who have no evidence of extrahepatic disease, people who are technically unresectable, and people who have biomarkers that are not disfavorable, meet the low Oslo criteria. It's still quite a low percentage of patients with colorectal cancer, but it's not zero, and there are cures for many of these patients. So we use live donor liver transplant. At Cornell, we have one of the largest living donor programs in the United States, performing all of our donor surgeries with a minimally invasive approach. We also use machine perfusion, enabling us to do complex operations. And there's a technique where you remove part of the liver and do a transplantation, and then come back in a few weeks later and remove the rest of the liver to enable a live donor liver transplant. So our protocol is 3 to 6 months of systemic therapy, a robotic lymphadenectomy, often if the primary hasn't been resected, 3 to 6 months of systemic therapy plus or minus lobar Y90, work up a living donor, and then proceed with live donor liver transplant. This is a paper out of American centers showing excellent outcomes, kind of replicating the European and Norwegian experience with excellent overall survival, and a very acceptable recurrence-free survival. So back to our clinical case. So she underwent a lymphadenectomy. So we perform these robotically. So what you can see here is the portal vein and the lymphadenectomy, getting all of and the hepatic artery. And so we completely dissect the hilum to ensure that there's no lymph nodes. So hepatic artery, bile duct, and lymph nodes are the only thing left in the hilum, to make sure that there's no evidence of extrahepatic disease. And so she underwent a liver transplant about a year and a half ago. Basically, in summary, parenchymal approaches reduce the morbidity of surgical resection. Liver transplant can provide significant survival benefit to people with extensive colorectal mets. Patient selection is critical to achieving good outcomes. We assess biology, tumor burden when selecting patients, and post-transplant recurrence is not defeat. Many patients with pulmonary isolated mets do well for many years. So with that, I'd like to stop and
That's great.
Take any questions.
Great presentation. Liver transplantation for liver metastasis is something that when I was in training, it obviously wasn't an option. So tremendous progress in that field. We're a little short on time, but how do we get these patients to you? How do you get patients now, and how do we, if we run into a potential candidate, obviously you'll be the final judge, you and your team, how do we send them to you?
Yeah, so thank you for that question. And, so, um, really what many of these patients actually are in are being treated by medical oncologists because they have extensive disease and they aren't candidates for um, for traditional resective therapy. So that's really one of the things that we're if you're thinking about transplant and as a curative option for patients, sometimes it doesn't matter. Removing the primary isn't the thought if you have extensive liver disease. Assessing the lung continuously if you have extensive liver disease doesn't make sense because you're going to give systemic therapy anyway. So for patients who have no evidence of extrahepatic disease, no lung mets, no osseous mets or other areas, those are patients who we want to initiate relatively early in this process because we are going to recommend that they have their primary removed and a lymphadenectomy, and watch their response to therapy very closely. So that's how most patients are coming to us. They've started a systemic therapy with their local oncologist.
Great. Let's see something in the audience. For Dr. Samson, when is the right time to send a liver metastasis patient for possible transplantation? Similar question.
Yeah, I mean, it's so for I think many people will be evaluated for resection of their liver mets. Anybody who has been deemed, I mean, we're happy to see them earlier rather than later, but anyone who's been deemed unresectable, those are people that we want to be thinking about. Is there an option? The way I think about a liver transplant is just a big resection. It's just a resection where we don't stop when there isn't enough liver. We keep going because we're going to replace it.
All right. So not the mother of all surgeries, like Dr. Jafari referred to HIPEC and cytoreductive. Well, thank you, Dr. Samstein. We can stop the recording and